Thank you so much, Marilyn, for the introduction, and many thanks to Epicenter for inviting me to chairing this very exciting session that is very close to my heart. And it's also a very great pleasure for me to introduce the first speaker, who is Etienne Genu, who you all know. He's the director of epidemiology at Epicenter and epidemiologist. But I first met Etienne 20 years ago in his previous life as a water and sanitation engineer in Sudan. And it was also the first time both of us encountered hepatitis E. So we were both working in Morne with MSF just 20 years ago, actually. Etienne as a water and sanitation engineer and myself as a medical doctor. Morne used to be a small village of a few thousand people, but at that time was hosting around 80,000 displaced people in Darfur who were living in very precarious conditions with difficult access to water and sanitation. There was high risk of outbreaks. At the same time, there was an outbreak of bloody diarrhea going on. We were preparing for cholera outbreak. And we had a strange zoonotic outbreak going on in the camp with the high mortality in donkeys the carcasses of donkeys were lying all over the place. And then at one point, we realized that at the same day, we had 3 very ill pregnant women admitted in the hospital with high fever and jaundice. Of those two women died. And we started to think about hepatitis E, and the outbreak was confirmed. And in the months that followed, the whole greater Darfur region experienced a large-scale hepatitis E outbreak. In Morne itself, in the months that follow, MSF treated over 2,500 patients. Around 10% were hospitalized, and among hospitalized patients, the mortality was 18%, which was up to 30% among hospitalized pregnant women. As a clinician, for me, treating patients with acute fulminant liver failure is really, really difficult. We don't have treatment, so there's nothing you can actually do for patients. And even in terms of palliative care, the patients with hepatic encephalopathy, they are agitated, they sometimes have very high fever. You can't even use it's very difficult to use drugs to alleviate their suffering because they're all hepatotoxic and you don't want to make their condition worse. So really for me, even Ebola or anything else, as a clinician, you at least think you can do something, even if you in reality cannot. But here it was really hard. And then on the prevention side, I think it was quite similar. Etienne and his team, they were trying really hard to ensure that the water provided to the population is safe, properly chlorinated. But we haven't really seen any impact on the epidemic spread itself. And then a little bit later, we learned from a very well-done Epicenter study that, in fact, drinking chlorinated surface water was particularly increased the risk of having hepatitis E in them. So really a frustrating experience. If you don't know, the Epicenter really described this epidemic very well, and it remains probably one of the best described hepatitis E outbreaks in African settings, and you can read them in clinical infectious diseases. So both for myself and Etienne, this experience changed our life, and we thought public health is really important, and we went to study epidemiology after. So just for you to maybe give a little bit of background on hepatitis E in case. Just if you're not very familiar with hepatitis E is a very common cause of acute, probably the most common cause of acute hepatitis, but it's neglected, so no one really speaks about it. It's a cause of large-scale outbreak, particularly in Africa and Asia, and in MSF, we very often experience these outbreaks in displaced populations, so in the humanitarian settings. Most commonly, it's a self-limiting disease, but can lead to acute liver failure in proportion of cases and then to death. Pregnant women, particularly in the 2nd or 3rd trimester, are particularly decreased risk of acute liver failure, of high mortality, that can go up to 25 or 30% in our case. And there is also this well-described fetal loss, particularly the stillbirths. We don't have any clinical management options to cure the disease. And then, as described previously, the emergency water and sanitation measures are very challenging to put in place, and their impact is unclear. We also don't understand the epidemiological situation very well due to the very limited diagnostics available and long incubation period. Sorry, I'm really bad. Then really great news came in 2011 when the first hepatitis E vaccine was registered in China. So it's Hecolin, produced by Innovax in China. The vaccine, this is a recombinant vaccine that comes in 3 doses, delivered in 0, 1, and 6 months. It's only licensed for use in adults, about 16 years old, but it's very safe and it has excellent efficacy as described in a published clinical trial. Today it's only licensed in China and Pakistan, and it's not yet WHO pre-qualified. Yet the WHO issued recommendations for use to mitigate the outbreaks already in 2015. So we had vaccine registered in China in 2011. We have WHO position paper already in 2015. Yet it took many outbreaks, large-scale outbreaks, before the vaccine was used for the first time. So at least in MSF or in OCG, I would say, we really tried hard to put this vaccine in use in the most vulnerable population. But there were large-scale outbreaks in Niger, if you remember, in DIFA in 2016, countrywide outbreak in Namibia that lasted for several years with thousands and thousands of cases reported. Then in Burkina Faso, however, there was very little interest to use this non-pre-qualified vaccine by policymakers in the countries, but including in MSF, I think we were very few pushing for the use. But finally, the stars aligned in 2022, where the Hecolin was used as an outbreak response for the first time in South Sudan. And I invite Etienne to tell us the story from Bentiu. Thank you.
Thank you, Ida. Thanks a lot for the introduction. And yeah, it was a really long journey. And finally, in Bentiu, last year, after 19 years after Mornay and 12 years after the vaccine was licensed, we were able to vaccinate the first people, the first woman. So we did that in Bentiu IDP camp in South Sudan, in a big camp of 120,000. A camp that suffers from recurrent flooding and poor access to water and sanitation. In this dense, hard-to-reach area that we vaccinated all people aged between 16 and 40 years. So almost 27,000 people for 3 rounds from March, April, and October 2022. This one. Yeah. No? I didn't... What I did wrong? Okay, this one. So concurrently with this widespread vaccination effort, we conducted operational research. First, we aimed to describe and understand the population adherence to the vaccination campaign. Second, this vaccine is a recombinant vaccine that is known not to present any risk to pregnant women, which is why they were included in the campaign. However, this is a new vaccine. We sought to document its safety in pregnant women. And including pregnant women is crucial for 2 main reasons. First, they are at high risk of hepatitis E, as explained. But second, if you exclude them without a test, actually, you have to exclude all women of childbearing age. And finally, lastly, the vaccine demonstrated significant efficacy in a clinical trial conducted in China, where efficacy was assessed after 3 doses. Estimating efficacy after 2 doses proved challenging to limited number of infections. Hence, we sought to evaluate its efficacy of the vaccine in the South Sudanese context, particularly in a response to an epidemic following administration of 2 doses. So I will now try to briefly show you the main results. Yeah. So the first question on coverage, we found a high coverage of at least 1 dose of Hecolin vaccine after 3 rounds of vaccination, and no case of severe adverse event following immunization. We found no significant difference in coverage of at least 1 dose by age group or between pregnant or non-pregnant women. On acceptance, the 8 focus group discussion of 6 to 8 participants shows that participants were familiar with the disease, having experienced it directly or indirectly. The disease was perceived as serious among pregnant women, also among children and the elderly. The discussion revealed a high level of acceptability of the vaccine and confidence in those who provided it. The main barrier was the temporary absence during the campaign, and there is a demand for the vaccine to be made available for the children and people living outside the camp. So, on vaccine safety on pregnancy, we sought to answer two causal questions. First, to determine whether vaccination against hepatitis E during pregnancy increased the risk of fetal loss, and second, if vaccination before conception increased the risk of fetal loss. To do this, we conducted a cohort study to compare pregnancy outcome in vaccinated and unvaccinated pregnant women. An exhaustive census in this big camp of 120,000 people of all pregnancy was carried out in Bentiu camp after the second vaccination campaign, and women were revisited 28 days after the expected delivery date to document pregnancy outcome. To help overcome the potential biases associated with observational study, we used an emulated target trial framework in which the protocol of the ideal clinical trial that should have been conducted is specified and then emulated with observational data. So the relative risk of fetal loss between women vaccinated during pregnancy and non-vaccinated women was 1.1 with a confidence interval of 0.7 to 1.8. Similarly, the relative risk was 1 between women vaccinated up to 90 days before conception and unvaccinated women. The bias indicator, I will explain after a bit what does mean a bias indicator, show a higher but non-significant risk in vaccinated women, suggesting that there was no bias, or if there was a bias, it exaggerated artificially the risk in vaccinated women. In addition, we performed several sensitivity analyses by modifying the matching criteria, reducing the number of variables, including propensity score for matching, selecting some sample. For example, we excluded all women who reported vaccination only orally without card to prove it. And all these sensitivity analyses show similar results. So no evidence of increased risk in fetal loss. Sorry, I didn't show you the second. So the first was for vaccinated during pregnancy and the second before conception. To assess the effectiveness of the campaign in the field, we strengthened surveillance by seeking to detect and test all cases and by improving laboratory tests to certify cases. We carried out a case control study in which we recruited cases eligible for vaccination detected by the enhanced surveillance, so at the facility, and matched them with up to 6 controls according to age, sex, and place of residence, and this control found in the community. The case control study can be potentially biased because individuals seeking care at facility may differ from control in the community. To estimate this bias, we use a bias indicator, so we measure the effect of the vaccine in individuals exhibiting symptoms but testing negative for hepatitis E. And if not bias, this effect should be null. So to control this bias, we also use a test negative design comparing vaccination odds in HIV positive and HIV negative case. So that's the second test negative that we did. So in our primary analysis with community match control, we estimated a non-adjusted effectiveness of 2 doses of vaccine of 67.8% and 55.3% after adjusting for potential confounder. In our bias indicator analysis, we found those seeking care for non-hepatitis E acute jaundice were more likely to be vaccinated than their match control in the community, suggesting the risk of potential negative bias. The test negative design, which control for health-seeking behavior, estimated, as expected, that the unadjusted vaccine effectiveness was 80%, and after adjustment for potential confounder, 88.3%. In conclusion, we did reach the population. They did accept it. We had a high coverage, a good acceptance, and a demand from the population, even beyond the population we targeted. We didn't find any evidence suggesting any risk in vaccinating pregnant women. And despite the small number of cases, reduced dose regimen, 2 doses, appear to have been effective in reducing disease in this highly exposed population. Sorry. So I want to thank the Ministry of Health of South Sudan, which was a great partner. The WHO was really help us during all this journey. I want to thank all MSF staff who participate to this all this observational study, quite a lot. Thanks also the community of Bantu. And a big thank to Robin Nesbitt, the principal investigator, who couldn't be here. Alors, je le dis en français, qui peut malheureusement pas être là aujourd'hui.
Unfortunately, he cannot be with us today.
Et c'était Robin qui a mené la plupart de ces études.
And Robin carried out most of these studies. He was the main investigators. And I'd like to thank again Isa and Andrew. It's been a long fight, and I'm really proud to tell you today that we were able to vaccinate and measure the outcomes in that population.
Thank you, Etienne. I would like to now introduce the second speaker, who will speak about the second vaccination campaign against hepatitis E, also happening in South Sudan. And I just want to say, I think that's a really important step towards actual use of the vaccine, because I think now we are really translating this into practice. So it's not just a one-off MSF idea, but I think it's, at least in South Sudan, I think it's considered as an intervention to seriously consider in outbreak control. So Joe O'Muller is an epidemiologist, is a field epidemiologist. He joined Epicenter in 2023 and is working currently in South Sudan as epidemiology activity manager. So I invite you to present.
Hello, everyone. As you said, my name is Joe O'Muller, and today I'll be presenting on the hepatitis E outbreak in Fengak County in South Sudan, and our study of coverage and acceptance from this vaccination campaign of targeting women of reproductive age. Let me see if I've got this right. Yeah, great. So MSF has operated a hospital in Old Fengak since 2014. It's located in the Sud Swamp, which you can see in the image to the left, which has greatly expanded since an extreme flooding event in 2019. It does both inpatient and outpatient care for a population of over 146,000 people. And what you'll see actually in this map to the left is located not too far from Bentiu, where Etienne carried out his study and the outbreak shortly before. So since April 2023, we have detected 585 suspect cases of hepatitis E at the Old Fengak Hospital, 261 of whom have been identified as hepatitis E positive via rapid diagnostic test, and 21 of whom have died. Of those hepatitis E patients, we found 113 of them to be women aged 16 to 45, and 8 of whom who died, unfortunately, were pregnant women. And you'll see in this epidemiological curve to the right, as we were detecting these cases, there were 3 major events that took place. One you'll see in the pink is when we implemented a new case definition, which allowed us to detect more suspected cases in the hospital. And then in the green, when we began our first and second vaccinations campaign rounds. And you'll see a precipitous drop-off in suspected cases after the second round of vaccination. So since we first detected these cases in April, the South Sudanese Ministry of Health declared an outbreak of hepatitis E in South Sudan in Fengak County in September of 2023. OCP finalized their plans to conduct a vaccination 2 months later in November, and then in December began the first round of vaccination. And the second round began in January of 2024, and in February, Epicenter began its study of this vaccination campaign, and as we speak today, the third round is beginning now in Old Fengak. And so what this led to was this strategy conducted by OCP, which was designed very similar to Bentiu with some differences. So 3 rounds were designed following the manufacturer's guidelines of giving the doses at 0, 1, and 6 months, which corresponded to December of 2023, January and May of 2024, using the Hekelin vaccine. And this was done in 2 areas, the Old Fengak and Mariang Touch Payam areas. But the key difference for OCP was the selection in exclusively women aged 16 to 45. And this target population came from both the minimum age requirements recommended by the vaccine manufacturer, as well as both the feasibility, cost, and epidemiological evidence at the beginning of the outbreak, where OCP decided to cut off at the 45-year mark and exclusively select women that were both pregnant and non-pregnant. And the challenges faced by OCP in this area were immense. Unlike Bentiu, this is not a camp environment in the swamp. So the logistics to provide cold chain storage, access the area exclusively through boats and planes, as well as reaching these villages. You'll see in the bottom left, actually, as part of our study team trying to go between the different villages, which require traversing shallow and deep bodies of water, often by small canoe. And that also, another challenge was the health promotion and mobilization required to sensitize this community to a new vaccine and this very, very specific target population. And so some of the achievements of the vaccine so far have been, the vaccination campaign have been, they've reached over 10,000 women, and the expansion of the vaccination campaign into 2 new areas as well. So what the vaccination campaign didn't tell us, though, beyond administrative coverage, was what we wanted to look into as Epicent in this study. So we wanted to look into how much coverage we had achieved in the acceptance of this vaccine and vaccination strategy in the larger area. So we took a mixed methods approach, as well as included adverse events monitoring and hospital case-based surveillance with 4 objectives: vaccination coverage, acceptance of the vaccination campaign and vaccine, safety, as well as describing the outbreak. Today we'll only be presenting on the first 2. And the methods that we used to do this was a WHO coverage survey, standardized WHO coverage survey, as well as focus group discussions and in-depth interviews to gauge the acceptance in the community. So what was most impressive in the coverage is you'll see here that once we did this survey, we found around 94% of our participants that we had interviewed had received 1 or more doses through verbal recollection or through the presentation of their vaccination cards. And 77% had received 2 or more doses through verbal recollection or the presentation of their card. So in this study, we originally had a target population of 1,050 women, and we were able to surpass that and interview almost 1,250. And so once we had conducted this coverage survey and understood how many people had possibly received the vaccine, we also wanted to know how this was received, which is where the in-depth interviews and focus group discussions came in. And what we found was that there was incredibly high acceptance of the vaccine itself. At the beginning of the vaccination campaign and in these interviews, we found that many community members were driven to take the vaccine through perceptions of fear and high risk. And as they received more information through health promotion and sensitization and seeing cases decline in the hospital, there was a really positive impact in accepting the vaccine, understanding that it protects the community, that it was protecting pregnant women and women in the community. And you'll see in one of our quotes here that one woman we interviewed said, with the second dose, people have realized that spreading of hepatitis E has reduced and is no longer a threat to the community where it was killing people before. What was most interesting, though, is while the vaccine was very accepted in the community, the vaccination strategy, we actually struggled with our coverage, with our acceptance. And so this came down to 2 sub-themes within this acceptance of the vaccination strategy, the first of which was that the vaccination strategy didn't match the experience or the sensitization that had been done leading up to the vaccination campaign. And that was that in more people in interviews and discussions reported concerns about a strategy targeting only one group for whom the disease is more dangerous when they knew that it infected so many others in their community. And I think this came generally from an understanding of they had been told through the health and sensitization promotion campaign that the entire community was at risk, despite the vaccination selecting this group for a myriad of reasons. And then the second part of this was the vaccination strategy does not necessarily match the community priorities of fairness and equality and health for all, that they should be protecting their children, that they were even willing to share doses so that more people could receive some protection rather than only a few of their community receiving full protection. And this is also highlighted in the quote at the bottom, which says from a woman we interviewed that I think there is a problem because the disease is infecting everyone. It does not infect women in those aged 16 years. Hepatitis E does not wait until turning 16 to infect someone. It infects everyone. And so again, what we concluded from this qualitative assessment was that there really needs to be strong harmonization between the efforts of the vaccination campaigns, health promotion and sensitization with the strategy that was designed, so that the community truly understands why reasons were made and decisions were taken to conduct this vaccination campaign as we go into the 3rd round. And so with that, I'd like to acknowledge the South Sudanese Ministry of Health who allowed us to conduct this study and this vaccination campaign. Both Yolanda Waldang, the Minister of Health in South Sudan, and Peter Gakir, who's the Director of County Health in Fengak County. Again, Robin Nesbitt, the Principal Investigator of the study, who couldn't be with us here today. My colleagues at Epicent and my field coordinator assistant, TH, who led us through a lot of difficult times in the swamp. And finally, our team that braved incredibly difficult conditions to reach and access all of these remote villages in Fengak County. So thank you.
Thank you, Joe. I would then now like to invite also Melanie Marty to bring us from the practical experiences to the policy side of the vaccine. Melanie Marty is a medical doctor from Germany. She holds a Master of Public Health degree and she pursued postgraduate training in field epidemiology. She's currently working in the Secretariat of the Strategic Advisory Group of Experts on Immunization, the SAGE, who advises WHO on everything related to the vaccination. Thank you, Melanie. And she's also the focal person in WHO for hepatitis E and has hugely helped us to get these initiatives through. Thank you.
Thank you very much, Isa, and many thanks for the invitation and the possibility to present and dive into a bit in terms of the policy. So let me just... All right. So yes, as Isa mentioned, I'll shift gears a bit away from the field and dive into the policy that was outlined in 2015 by WHO and which is published in the 2015 vaccine position paper on hepatitis E vaccines. So in that paper, it is outlined that WHO recognizes obviously the importance of hepatitis E as a public health problem, particularly among special groups, including pregnant women. In the position paper, WHO does not make a recommendation on the routine vaccination of populations, but outlined that countries may use the vaccine based on their local epidemiology. That said, probably the more important policy that is outlined in that position paper is the possibility to vaccinate in outbreak situations and special groups, including in pregnant women, and the aim is really to mitigate the consequences of hepatitis E in these high-risk groups. So, as already alluded to by Isa, since 2015 there has been multiple efforts to use the vaccine, and it has been quite a frustrating episode in terms of not use of the vaccine despite having that policy in place. And the reasons for not using the vaccine were multifold, but that said, the limited data and the limited data was one of the reasons why the vaccine was not used, and it ended up in a vicious circle of not having data and not using the vaccine. So thankfully in 2022, that vicious cycle was now broken with the use of the vaccine in South Sudan. And these data generated really helped to reinforce the policy. And in March this year, SAGE retackled the topic, and based on the South Sudan data that were just presented by Etienne, SAGE reinforced the recommendation to really use the vaccine in these fragile, conflict-affected and vulnerable settings, specifically in those populations where the risk is really high, namely in pregnant women. SAGE also stressed that, as was done in South Sudan, that it would be really important to accompany any vaccine use by a learning agenda and the generation of public health research. Also, I think one of the rationales for SAGE to retackle the topic of using of a less than 3-dose schedule was the experience that came out of Sudan, that in these settings, the implementation of a 3-dose schedule at 0, 1, and 6 months is very difficult. And that was also outlined in the publication by Nesbitt et al. So SAGE looked comprehensively at the data of using a 2-dose schedule at 0 and 1 month and concluded that in these particular settings, a 2-dose schedule may be warranted and could be used. And then obviously SAGE encouraged additional research on hepatitis E vaccination during pregnancy. So just two other aspects that I'd like to mention. The first one is that there's a vaccine stockpile that was approved under the ICG, the International Coordination Group, last October. That would be the 5th vaccine, and it would be what we call proof of concept stockpile using the current non-pre-qualified vaccine for a period of up to 3 years. So this mechanism is currently still being put in place, but we hope to have that up and running soon. And the second and last aspect that I'd like to mention is that Gavi is also considering the establishment of a hepatitis E vaccine stockpile using the pre-qualified product should it be available. And there have been some positive signals from the Program and Policy Committee last week, and that will go to the Gavi board in June, and hopefully with a positive result. So I'll stop there. Thanks.
Thank you so much for Melanie, for the intervention. Maybe just before we jump in the discussion, I wanted to make a comment. I think we have really come a very long way on the hepatitis E, extremely frustrating way, so please don't give up when you think things are not moving, because sometimes they will move in future. However, I think where we are today is that 20 years on from the our experience in Mornay, and linking to the first presentation on the, as you know, there is a war in Sudan with a large displacement of population again in Darfur, massive displacement into Chad, and in Chad right now we have also a big hepatitis E outbreak with I think over 2,500 cases reported to date from all the camps along. So now we have the vaccine, we have the policy, everyone agrees we should be vaccinating, but actually we are not vaccinating because I think mainly because of the logistic reasons, the cost, and so we are still discussing, but it's been months and months and nothing has been done so far. So with that, I want to open the floor for discussion. I'm supposed to have, I don't know if there's any questions online. No. We're supposed to be, okay, perfect. Thank you. Yes, please.
Merci. C'est Raphaël.
Thank you. Raphaël, MSF.
Je vais poser une question à Étienne et puis une autre question.
A question to Etienne and another one to Melanie.
C'est très bien qu'on se soit intéressé.
Now, I think, Etienne, it's really great that we looked into this case of and the impact of vaccination on pregnant women, and to see whether this could lead to a termination of pregnancy. But as you said, there's been no evidence so far about the impact of the vaccine on pregnancy. However, when reviewing patients' records, what could you gather from other studies on this particular issue? And my question to Melanie is this one. I think WHO recommends 2 doses today, as far as I know, instead of 3. Well, at least this is what I could read about WHO's recommendations recently. So what did you take into account to go down from 3 to 2 doses? Is it the efficacy of immunogenicity, or were other elements taken into account?
Je vais répondre en français. Donc sur la première question, qu'est-ce que disent les autres?
About your first question about other studies looking at the impact on pregnancy, we looked at safety and whether it was harmless, and then we looked at all pregnant women's cases in Bentiu. Up to now, pregnant women had been excluded from clinical trials. However, some, let's say 100 pregnant women were inadvertently enrolled where hepatitis E Vaccine was used as a control, and in these centers where women were vaccinated but were not meant to, there was no problem. And it's a recombinant vaccine, so normally it shouldn't be a problem for pregnant women. And then there was a study in Bangladesh excluding pregnant women, but well, here again, they're vaccinated quite a number of them inadvertently. The results haven't been published yet. And going down from 3 to 2 doses, over to you, Melanie.
I'll answer in English, if I may. So yes, SAGE in March this year recommended that a 2-dose schedule could be used in these fragile, vulnerable, and conflict-affected settings, really to ease the implementation in these settings. And that was backed up by a comprehensive review of literature on immunogenicity, efficacy, and effectiveness. That review is published on our website if you're more interested in that. But I think the main conclusion is that there's a high efficacy and also immunogenicity of 2 doses, and that was mainly out of the large phase 3 trial, which included more than 100,000 individuals in China, and where there have been now follow-up data for 10 years that really inform that the vaccine is immunogenic in a 2-dose schedule.
And maybe just to add to that, I think like in the context, at least in the context of South Sudan, there is probably a very high pre-exposure of the population to the hepatitis C. So maybe the vaccine actually, we don't know, but you could assume that the vaccine doses, they serve as a booster to the previous infections. Yes, please. There is a question here.
Philippe Guérin-Ido, Isa and Etienne, you haven't changed in 20 years. That's good. I was looking at the mortality in Mornay. It was about 20% or 18% at the time, and you are reporting something like 10%. There are not that many diseases which have a mortality of that high with no therapeutic options. And I wonder if there have been any discussion with CEPI to try to promote the idea that actually hepatitis E has a real potential of outbreak, which is their mandate, not quite pandemic, but certainly large outbreaks, and if that could be also added to their portfolio, because they could bring funding. Because I'm quite surprised, after 10 years of having a vaccine register in China, or more than 10 years, it's not yet pre-qualified. As far as you are telling, there is only one manufacturer, and that's not a very good place to be. And then my last question will be on to Joseph. So you vaccinated in the second camp, or the second displaced population. Do you have a mortality assessment on that population?
So I can respond first because it's the simplest answer. No, we don't have a mortality assessment just yet. So it's something that maybe we could do in the future, but not at this time.
Sorry, I just want to correct, because I mentioned 18%, but this is a hospital mortality among hospitalized patients, not overall. So I think overall mortality, I don't remember, in Mornay was maybe 2-3%, and in most of this outbreak it's around, when you take all the cases, and that's of the hospitalized patients, not confirmed. 18% amongst hospitalized patients, so that's how the paper was published from Epicenter, and with your supervision, I think. Do you want to speak about CEPI?
Sure. On the aspect of CEPI, and just to point out that it's quite a positive development also that Gavi is looking at it under the vaccine investment strategy, and again, hopefully there will be a stockpile put in place. I think the issue is not so much in terms of the vaccine itself. So, I mean, we have that tool in place since 2011 now as a licensed vaccine. Just a side note, there's also a second manufacturer that has its product in the clinical trials now. Again, I think the issues of not using the vaccine are multifold, and one of the main issues is probably the lack of pre-qualification I think there have been multiple attempts to encourage the manufacturer to proceed with that, and they're planning to do so once they have their new facilities set up. But obviously this is not happening at the pace at which we would like to have it happen.
But it's also a disease of, it's a neglected disease among neglected populations. Right? So I think the outbreaks we see, they are in displaced population, in the refugees. Even in Namibia, that was a very large outbreak. It was only concentrated in the slum areas. So even if it was in the news every day, it wasn't actually a problem of the decision makers. And I think the hepatitis E really suffered. It's not dangerous enough to be on high on the political agenda. And it's, I think it always drips under the radar. Any other questions? Yes, please. There, and then there's one there.
Karine, MSF. Je pense qu'il a été fait mention d'Adré, où effectivement...
Someone mentioned Adré, where an outbreak was suspected as of January. And when we started the operational discussion, some of us were quite surprised because some MSF colleagues on an intersectional basis wanted to launch a campaign for the general population, adults and children, and both genders. And when you take a look at the incidence and the fatality rate today, I think it would be interesting to get some results about transmission that would justify an extended vaccination program. Or do these two experiences show that for hepatitis E, it's good enough to focus immunization on women in reproductive age? Do you think it's worthwhile to try and target more widely?
We are a bit limited with the vaccine anyway, because the vaccine is not licensed for use in children. So I think we really need more evidence before. There is trials ongoing, so maybe in future there's going to be new recommendations and new registration of the vaccine. But for the moment, we are limited. We can't really use vaccine in the population younger than 16 years, right? And then I think when it comes to the older men and women, I think, of course, the pregnant women in particular, they are at very high risk of severe disease and dying. But men are also sick and they are also dying. So I think it's the question of, of course, I think either way it's justified. But when you look from the equity point of view, as was seen, I think, from old Fangak experience, it's a tricky question. I think the current outbreak in Chad also shows how tricky it is. I think that from the experience we have in MSF from the large-scale hepatitis E outbreaks, they don't behave all in the same way. In Morne, we saw like a really, a massive outbreak with a lot of mortality at the very beginning. But then other outbreaks, they would last for years, and it's not super dramatic. But there is, it's a slow progressing disease when you end up at the end with tens of thousands of cases and hundreds of deaths, but over a period of 3-4 years. I think maybe today in Chad, we don't see, I think no one in Chad today has experience we had in Morne at that time, because the numbers are not as big and the severity today doesn't seem to be that big, but we don't know what will happen in the future. Question here, sorry, first there, and then there's one question behind and here, and then probably we have to...
Ma question est orientée. Romaric de l'Institut Pasteur.
Romaric, Pasteur Institute Bangui. My question is to Joseph. In your methodology, you show that you plan to review the adverse events. I couldn't see that in the results. And did you carry out an attributability study?
So for the adverse events in Old Fengak, so it's been quite a challenge operationally to monitor them, because what's different about Old Fengak compared to Bentiu is it's not a camp. So Old Fengak, where the hospital is located in the swamp, the closest villages are usually 30 minutes to an hour by boats, and then they're very spread out. And so to reach all of the different community healthcare centers to establish proper adverse events monitoring, and then also to follow those up and have all those results collected were very difficult for the team in the first and second rounds of the vaccination. So a lot of our adverse events monitoring is something that we're trying to correct in the third round. We haven't had any extreme adverse events reported. There were very few, I think, in Bentiu as well. So we knew that the risk was low going into the campaign in Old Fengak. But so far to date, it's been a very big operational challenge for the proper implementation of following those adverse events in all of these areas, just because of the fragmentation within this swamp, and maintaining that and managing those teams, both between the Ministry of Health and for the MSF staff.
Pardon. Oui, c'est ça. Juste pour répondre ou compléter un peu à la question de Karine sur...
Just want to go back to Karin's question about the best strategy in population. There was one thing that wasn't mentioned, i.e. Also the community and Watsan are also important. Reproductive age women is one thing, but you need also to take into account the way you can do away with the transmission chains. This is what we are seeing in Olfangor. We know that the epidemic could go on, could be protracted. So what do? Should we just target people on the basis of the CFR, on the case fatality ratio, or it's a very complex situation.
How complicated altogether is. So I'd just like to take the question there from the back, because it's been since...
Mathilde Berthelot, MSF.
Mathilde Berthelot, MSF. On top of this vaccine, are there any treatments in the pipeline?
I think that the answer is more or less no. So there is the ribavirin and some other antivirals that are being used for treatment of chronic hepatitis E, especially, and also acute hepatitis E, but in the context of genotype 3 and 4, and so a very different disease. But I think it's very difficult to, and I think it's going to be difficult for antivirals, so it's probably we have to think other things to work, because the acute fulminant liver failure in hepatitis E, it's really killing people within days after the onset of symptoms. So it goes very fast. And I think like the ribavirin, when you read the papers on the chronic infection, it takes like weeks or months to decrease the viral load, or to reach undetectable viral load. I think we have to. I think we have to stop. Sorry. So I think apologies, and please do reach to us in the during lunchtime, and we'll be happy to discuss more. Thank you so much, and sorry.